S.N. Vani ma'am, Dr. Raju C. Shah, and Dr. Bardev Prajapati. They collected a very handsome amount and fund and invested in a fixed deposit. Amount received is used for the organization for the oration every year during only midterm scientific conference. Many learned academicians have delivered this oration till date. This year, it is awarded to Dr. Bardevbhai Prajapati, Professor of Pediatrics, GCS, Medical College, Ahmedabad. I'll now request Dr. J.K. Gosai to introduce Dr. B.S. Prajapati, sir. Thank you.
That's my privilege to introduce sir. Welcome, sir. Today, our orator is Dr. Baldev S. Prajapati, sir. Everybody can know about them. Fortunately, sir is a student of A.B. Desai, madam. He is a debate MD Pediatrics gold medalist. He is a professor and at GCS Medical College and Hospital at Ahmedabad. He is a popular teacher, academician, examiner of the various state and across the India. They are also awarded FIAP 2015, Executive Board Member, Central IAP in 2002, 2003, 2005, 6 and 11. Chairperson of the ID Chapter IAP 2009. Members IAP Committee on Immunization 2009-2010. President IAP Gujarat State Branch 2003. Authors of many books. There's published a lot of data, more than 92 publications. It's my privilege to welcome sir for the oration. Thank you, sir.
I think still it's a time for the good morning. Is it working? Good morning, friends. Say at least good morning. Good morning. Yeah. My dear chairpersons, President Dr. Swati, Secretary Dr. Janti, AOP Gujarat State Branch, respected and my beloved teacher Dr. Mrs. A.B. Desai, Madam Vani, distinguished guest speakers Dr. Raju Chandani and Dr. Anand from Mumbai, my dear friends and my family members. Fortunately, some of them are present here today. Before I go for this oration, let me express a word of gratitude to the office bearers of AOP Gujarat for awarding me this prestigious oration on the name of my own teacher, beloved teacher, Dr. Mrs. A.B. Desai. I would like to pay the respect to these four institutions. BJ Medical College is my mother institution who taught me the ABCD of medical science. LG Hospital, which provided me for working as a teacher for more than 20 years. And I learned how best I can learn and teach the pediatrics. Since last 5 years, I am working as professor at GCS Medical College with really very wonderful experience. And my own private hospital, Akanksha, probably offered, gave me everything in my life, besides academics and everything. With this, let me remember my parents. They taught me the philosophy and values importance of norms in the life. My in-laws always encouraged me in my all endeavors, especially the academics. My teacher, Dr. Miss A.B. Desai, probably very important person in my life, I will say. She taught me not only pediatrics, many things in the life, including how you can be the good human being. Till today, I am learning from Dr. Ambedkar how best I can teach the pediatrics. And I will never forget Dr. Vijay Kinariwala. I think some of them must be knowing from BJ Medical College. I have done only MBBS term with him. He used to say daily, I am not to teach you only the medicine, but how to live the life. In the true sense, he taught us, especially me, how to live the life. With this, let me start the topic, quality in pediatric practice, as I view it. I have restricted, keeping in mind the views of general pediatrician, because I am general pediatrician. And the facts which I mention over here, these are the facts which I learnt during 36 years of my learning the pediatrics from day one of my residency. Friends, let me start. What do you mean by the quality? We know that quality is providing services of desired standard with the current science. And it is not an accident. Quality is never the accident. It is the result of well planning, perfect execution, and with the best efforts. And we know that medical practice is a profession. And what is profession? It is a skillful work, rewarding and satisfying the person, probably at even the retired age. And in a profession, the person gains some return of working. And friends, return is the byproduct, never the goal. And that's why what Mother Teresa said, medicine is a mission, even not the profession, and never the business. I know that the person interested in the profession gets involved in the working, enjoying the work. He does not feel burden of working, never getting tired, no frustrations, no time limit of working, and gives best of his ability. And that's why what the William Osler said, the very first step toward the success in any occupation, any profession, is to become interested in it. And I think that now we should take care for our kids. Whether they are interested in whatever, probably they should go. What are the qualities expected from us? Easily accessible and available. Sincerity, punctuality, and meticulous working pattern makes a difference in the quality care. We'll have to learn, unlearn, and relearn daily. And therefore, even the reading should be the integral part of our daily working. To be very frank, friends, to insist to my students, since last 5 years I am taking the round with the Nielsen in this kit. And occasionally even the light tone I say that whenever I am absent, you take the round with the Nielsen. I want to insist them that book is important, open there, see it and check it. Even I like it, and I may suggest friends who are interested, keep at least a small library at your working place. And I'm sure that it is an asset to the person to keep him updated in the subject. Friends, I think now the youngsters, we know that open the net and whatever the reference you want, you are able to get next moment. Utilize how to use it. What I mean to say, whatever you want to do it, but do it with the recent information. And I'm sure that that will offer the best of best quality, otherwise never possible, in spite of the seniority. What is the medical practice? Not only the science, it is an art. And we know that any art cannot be learned without the devotion, not by the textbooks, special efforts, and absolutely true for our medical science also. And these are the components of the medical practice. Knowledge and recent information. हमारा स्टूडेंट एमएच पे एक जादू चाल से बाकी ना कोई जादू चाल से नहीं. We know that detailed history taking, examination, go for the analysis of the information, laboratory investigations and their proper interpretations, audit, ethics in the medical practice, efficient administration, counseling, very important component of this quality of the care, and research, whatever at even the small place we are able to do. Unfortunately, you know that Dr. Ambedkar very often said that this is the pattern of the present practice. That is the miss pattern. As soon as the patient enters, we start the management. And then we fail, we ask for the CBC. When CBC is normal, then we ask a fever kitla divasi che. and then probably we know that we fail to manage. Ideally, it should be the heat pattern. Go for the history, investigations, and then management. What is the importance of history we know? Patient hearing is one of the good qualities of any clinician. Very important. And patient listening to all that the patient wants to tell is never the waste of time. On the contrary, it may offer the clue to their diagnosis. Information by the patient is never vague. And friends, remember, patient and their family members may be illiterate. Still, their observations are more reliable than observations made by any other person, including me and you. And that is the absolute inaccurate truth. If I give some of the illustrations, this is absolutely, I received a phone call from the mother of only 2 days child with a good weight. Then my child is having the difficulty in breathing while taking the breastfeeding, becomes blue, starts to take the breastfeeding, cries and becomes a pink, and no respiratory problem. And friends, you know sufficient to say it is bilateral choanal atresia. Just to listen the mother. Diagnosis is clear. I remember this patient I received from Himmatnagar, 3 months male, only breastfed, with persistent jaundice, hepatomegaly and convulsions due to hypoglycemia and no fever. Torch was negative. On 4th or 5th day, I remember after the hospitalization at my own place, illiterate, very young mothers asked me, "Sir, is there anything in the eye?" Which I was not knowing. I came to know, oh, it's a cataract. And then I said in the Gujarati, Janmathi ase apne rubella fari kariye. And that young lady said, "Sir, it was not since birth. 15 દિવસથી મેં જોયું છે." And I told my pediatrician, now we have failed everything, listen to the mother. It is acquired cataract. If acquired cataract, then we went for the galactose 1-phosphatidylate transferase enzyme and turned out to the galactosemia. Treated with the cataract operation and everything, now she is doing very well. What I want to convey, respect the complaints or observations of the parents. Maybe the illiterate. And they are never vague. Don't say they are illiterate to understand. To understand us. They are very well understand us. We are always in hurry, overburdened, but define whatever the symptom. If I give the example of fever, say it is prolonged fever. I said viral, but now 10 days, 2 weeks time, but still viral. Then Epstein-Barr. That's the thing that how we can able to answer. Is it recurrent, periodic, fever without a source on 4th day, fever of unknown origin? What I mean to say, categorize the symptom. That categorization will give you the idea that what is to be done. Even simply diarrhea, acute watery of short duration, only ORS and zinc. No investigations, nothing. But beyond 2 weeks, I will have to give you the thought. And when particularly mother says, very long duration, I don't remember, weight loss, malabsorption, my approach will be quite different. Friends, from these illustrations, what I want to convey, even any illness or symptom, try to define the pattern, and that will give you the clue that what should be the exact your approach. Don't jump without any categorization. Here I remember that this was a child 2 months male with a severe pallor, hemoglobin 4.7, CBC otherwise normal but organomegaly, platelets normal and diagnosis thalassemia major. Parents were not happy and that's why they came to me. When we went for that 2 months old child thalassemia, reticulocyte count less than 1, parents were negative, bone marrow confirmed diamond black fan syndrome. Friends, what things should come to your mind? Dr. Ambedkar has mentioned in the book, history begins with the age. What is the age? 2 months. And therefore, simple febrile seizures not usually under the 6 months, Kawasaki less than 5 years, rheumatic 5 and 15, chorea probably not less than 10, and pneumonia in older child not respond to antibiotics, maybe the mycoplasma. Probably cough, hardly we pay the attention, but neonate complaining of cough, I will not overlook. What I mean to say from some illustrations, age is very important. Just check it and that will be the answer. Here it is the 8 months female from Gujarat. I remember that cough of 9 months and mild fever, decreased appetite, no response to any antibiotic. Even CBC was normal. This was the chest X-ray. I remember that echo was done at Baroda reported as normal, and they advised for further workup. Patient was referred to us. We went for the lateral plate and we went for the CT scan of the thorax. Turned out to be the bronchogenic cyst. 9 months only dry cough. That is something irritating the tracheobronchial tree. And looking at these type of shadow, probably in the 18 months, and with 9 months, some malformation. Just if you look at probably this type of analysis, most complicated, uncommon, but you can diagnose very easily. Respect the chief complaint. And therefore, I remember Dr. Ambedkar very frequently, probably I will mention in my talking, but he always said that what is the chief complaint? That it is very important. And chief complaint may be the important clue for your thought process. This was an 8-year-old child with a high-grade fever of 103 in the evening, previous evening. Next day, even the breathless, and with severe breathlessness hospitalized. Span of only 1 day. This was the CBC, almost normal. This was the chest X-ray. Reported as pneumonic effusion. No response to the antibiotics, referred to us. We went straight away, US guided this pleural tapping, turned out to be the tuberculosis. What was my point? Same pneumonic effusion without pneumonia? First pneumonia will be there, then same pneumonic effusion. Here pneumonia was not there at all. That means cause is something else. And that we know that allergic reaction, this type of the presentation is known. This was the patient I remember the LG hospital few years back. A servant working in the hospital came with his daughter of 12 years with high-grade fever and cough of 1 day. But because he was in the LG hospital, came with his X-ray. An X-ray was reported, left mid-zone pneumonia. I remember Dr. Anjana Ben taking the round that my clinical diagnosis may be pneumonia, radiological may appear later on. Here radiological appear first and no clinical. I said how it could be. I asked the servant that probably X-ray changed with some other patient. He said, no, sir, maro chaunt laine aave chu. Then I said, you repeat it. And on repeat, after 30 minutes, X-ray was clear. And therefore, I have given the title that pneumonia treated within 30 minutes without any antibiotic. How it could be? That was the tuft of the hair of 12-year-old girl, very, I will say, very long hairs, and in the lying down position, artifact. What I mean to say, don't treat that X-ray and that opacity. Only 1 day, you know that infection, pneumonia, localization is going to take time. So that's the point that how we'll have to take. And that's why what we should remember. Origin and duration of the illness, how it started, what's the origin, what's the duration, that will give the clue, probably what we are thinking is right or wrong. This was a 2-month-old child, again this is the probably old patient when I was resident in the second year. 2-month-old child hospitalized for pneumonia. I think some of my friends, my colleagues will remember. Child developed the fracture of the shaft of the femur when my friend Dr. L.J. Shah is at USA at present, otherwise he must be present. He was taking the blood by the femoral puncture and child developed the fracture. We referred the orthopedic surgeon applied the plaster. We were happy. Next day when Madam Desai came in the round, she asked the first question, okay, fracture the LJ femoral karele fracture thoda thai jaye. Without any trauma. And what the madam showed, that even the sclera is blue. We went for the X-ray, turned out to the osteogenesis imperfecta. Way of thinking. Another child I remember from Dr. Bhavin from Nadiyad. 10-month-old child. He said, sir, in a thoda kalak mas out back extensial the oral thrush. We don't have the answer. Healthy child. All investigation, everything was normal. When referred to me, I was also not clear. But when we got the detail of history, that child is looked after by the auntie, a case of sterility. She will take utmost care of the child, everything for food and clothes and everything. But whenever she develops the impulse, acid in the mouth, and that extensive ulceration, naturally we will say it is oral thrush. This is the thing that how we will be able to reach the diagnosis. Friends, important to consider clinical setting. In which clinical setting the disease occurs? Is it possible just he fell down from here and the problem, head injury, intracranial bleed? And if at all it occurs, that means some unusual circumstances. And we know that it may offer the clue to the hidden diagnosis, and therefore, don't ignore the clinical setting. Go in the details, how it happened, and I'm sure that you'll get the answer. This was a 6 years old female from Kadi, Dr. Naveen Patel referred with the jaundice and diagnosed viral hepatitis. It was very simple, but patient developed the generalized edema and ascites. It was obvious hepatitis A positive, but patient deteriorated very fast and developed even the icterus and edema. All the investigations were now negative. When we went for further workup, turned out to the Wilson disease. Friends, what the message I want to convey? If a patient of known condition, pneumonia suppose, takes undue longer duration for recovery or unusually deteriorates, think of its complications first or associated other diseases. And therefore, unanticipated progress of the disease is very important and it offers the clue to the diagnosis. This was a 3 years female of illness 2 months from Gandhinagar, constipation, pain in abdomen, vomiting, treated by pediatricians, surgeon, laxatives, enemas, so many things. CBC was normal, USG abdomen was normal. USG abdomen done 3-4 times. When we asked that how we can explain, on detail, weight loss 615 kg in 3 months, mother said, although this child is eating very well, still this loss is there. And said that passing urine frequently, even during the night time, which was not there before. And excessive water intake. Friends, if you go for this information, I think undergraduate will say it is insulin-dependent diabetes mellitus. The only thing, you have to go for these details. And I'm sure that you are going to get the answer. This was a 10-year-old male from Modasa. Sudden fall and unconsciousness in the school. Taken to the neurologist, diagnosed in absence of normal MRI and EEG nor epilepsy on sodium valproate. We also could not say answer. I said due to the sodium valproate, the weight gain is possible. But after 3-4 months, when he came with the mama of the child, that father is lost due to some sudden problem, probably cardiac. And he said, mama, that was sudden death of his uncle 2 years back. Then I said the weight gain and all these, what I say, epilepsy, probably which we are not able to understand. First, let us go for the ECG. And Milan Chak did the ECG and he talked to me, it is the WPW syndrome. Wolff Parkinson White syndrome, probably only 2 patients I have seen, one of them. Child was operated for aberrant conduction pathway, at present doing very well, very well. I think this is the thing that how we learn the medicine. Importance of detailed history. And when we fail for the routine probably, go for personal and family, at least go in the details, you will get the clue. We have learned from some of the teachers that our first impression sometimes works very well. I think youngsters know that the first many times works very well in many fields. Just mere look at the patient. And probably not only the diagnosis, but it helps you for guide for the urgent intervention. And please remember some of the things which I have taken as the red flags with the fever, ultrasensorium, drowsiness. I think we cannot wait. Fever in a neonate, we cannot overlook. Signs of impending shock perfusion, whether I understand or not, it requires attention. Petechial skin lesions of bleeding, probably some serious condition, either dengue or meningococcemia. On throat examination, membrane with sick-looking toxic child with lymphadenopathy, diphtheria. Don't wait for the stain and everything. And if I get the phone call, known case to me that nephrotic syndrome or HIV or something, even mild complaint of fever or pain or anything is always serious to me. And we know that guarding a rigidity always take the help of friend pediatric surgeon. We know that even just from your round, purpura but sick looking, I think somebody was talking, leukemia, my first impression. But child is happy, good looking, ITP. Generalized edema, but child is sick looking, I think dengue. But happy child, nephrotic. But that nephrotic now sick looking, some infection. And complaining of abdominal pain, peritonitis. I know that confused state of the child, whether I am able to say or not, but hypoxia or poor perfusion. And we know that in this season particularly, the newborn, younger the child, extreme irritability or convulsions following diarrhea or fluid loss, hyponatremia, and if I don't understand, child will die due to the intestinal hemorrhage. Screaming child following the diarrhea, I would like to exclude them into susception. And I'm sure in the life of the physician, probably just this observation makes a difference in our daily practice and offering the quality. I remember this child was from LG hospital since 5-7 days, 2 months male, fever, cold, irritability, ictus, organomegaly, lymphadenopathy. The only point which I observed that in my round, when I was checking for the pulse, child was crying. Otherwise, even when I examined for the AF, liver, spleen, not that disturbed. I said, why the child is crying when I touch the wrist? I asked for the X-ray wrist and turned out to be the osteitis. And then osteitis, then we went for the analysis. So many points were there. And therefore we investigated and turned out to be the congenital syphilis. What are the marker? Only pain on touching the wrist. Okay, then everything was clear. As per the standard textbook of Nelson. This is the lesson which we can learn. This is the patient from Veeravan, 7 months male, weight was less, cough of 3 months but no fever, echo was showing some malformations, cardiac, treated with antibiotics because it was collapse on the left side. The chest X-ray was done 5-6 times, every time the same picture. And that was having some problem and therefore referred for even the CT thorax. When I saw that the child is nutritionally poor and the hemoglobin is 16 and the clubbing is there, then I said probably CT thorax is not required. It should be some cardiac. We went for this echo, turned out to be total anomalous pulmonary venous return. But I said, I asked Milan that why this collapse? He said that go for the aortoangiography. That was the vascular ring compressing the main bronchus. Very poor patient, operated at UN Mehta, doing very well at present. I think these are the lessons which we can learn from simple observations. 13 years female referred from EDER for persistent anemia not responding to all the hematinics. And you can see the serial CBCs. Probably DC and everything was normal, but hemoglobin was low. Even our reports showed that it's very bad hemoglobin, but rest of the things were not indicating except iron deficiency anemia. Further, even parameters confirm that it is iron deficiency anemia. And then why the still patient is not responding? When I saw in the round, then I'm expecting either the platelet or cholinuclear with iron deficiency, but this patient has the clubbing. That was the only marker. I said go for the seromarkers for celiac disease, turned out to be the celiac with refractory iron deficiency anemia. Marker was only clubbing. That's the thing that how it helps. 14 years female was referred with severe anemia not responding to again oral iron. And when I saw the diagnosis was obvious, look at the hyperpigmentation of the knuckles and see the MCV. This was done by the previous pediatrician. We have not repeated. MC diagnosis was clear. So look at the papers done by somebody else also. But we don't because we don't have the time. We are so much busy. So let probably offer the compromise quality if you are doing like that. And they confirm the megaloblastic. These were the 3 years male. Refer for persistent raised hemoglobin, again by my friend Dr. LJ from Godhra. This done for just viral infection routinely, and SGPT was constantly high without any explanation every time. Learned parents from even working at Ahmedabad referred to me. I also investigated. We could not answer. I said even I planned for the liver biopsy. Somebody asked, there was no indication. Meanwhile, friends, what I observed probably on 3rd or 4th visit, I said, okay, after examining, niche aavi jao. And just I was turning and I saw that how child is getting up, rolling upon and then taking the support and then getting up. I said, oh, it is incomplete goer. Then retrospectively, I saw the calf muscles, little bit really prominent. We went for the workup, turned out to be the Duchenne muscular dystrophy. No investigations helped me. Just looking that probably this, and you know, incomplete goer, later I checked that it will be at 2 and 3 years, complete will develop 5 years. 5 years, mother ke muscles ruche. But before that, we'll have to answer from these things. Friends, what I want to convey, just a clinical pointer, that pointer will have to search with the torch. And that pointer may be just your observation or physical examination. And that clinches the diagnosis, does not require anything else. That's the thing, lessons which we learn. Growth charts. I remember the LG 10 years back when I started to learn growth chart, I said कि ना भरो तो ना भरो पर केस पेपर ही जोड़ो growth chart तो जोइए नाम ना लखो तो ना लखो. I told my residents. Now they are doing very well. Occasionally I am learning from that. Most neglected part, I think any practitioner should do it. There is no excuse. So many things you can diagnose. It provides the information regarding nutritional state. Not only that, if you go in the details, when the disease started, you can say even the date. You can say that when in between even child recovers, you can compare even the parameters, and probably no investigation may require, and if at all requires, it is for the confirmation. We know that if you know simply this thing, in the everything height and weight is affected, probably either some chronic disease or malnutrition. When I come to know that height is less, but it is corresponding to the skeletal, probably it is a constitutional, don't do anything, child is going to grow in its own way. But when I note it, that height is affected, but weight is good for that height, dogmatically you can say it is some endocrinal problem. And we know that every parameter is above the normal. Probably now, what common scenario is our nutritional obesity. Probably the miracle thing you can do. Many times I know that refer to me for the growth hormone. I said don't do anything. Either I got the celiac or occasionally I got even the obstructive uropathy and no growth hormone deficiency. I was not knowing hand foot disease some years back. Probably I learned from Cochin 7-8 years back from Dr. Pisharodi. He said 100 cases of hand foot disease. I said, oh. And now we know this is not uncommon probably for this gathering. We do come across, the only thing we'll have to relearn. We know that the prolonged fever with this type of picture, infectious disease of mononuclear, we were taught that it is not the disease or problem with us. Absolutely wrong. We do come across, and if I put some of the reports, probably many other with most of the friends, it is not an uncommon condition. This was a 9-year female from Modasa, very high-grade fever, hepatosplenomegaly, patient presented with a shock directly. But the history very important, trauma or just abrasion on the left knee while playing in the school. And this was the picture. You can see all these clinical even the changes over the skin with the shock. And that's the thing. Later on, culture, we got the staphylococcal and friends, staphylococcal toxic shock syndrome. Even I have seen the streptococcal toxic shock syndrome. I think friends also must have seen. These are probably new variations or development of the streptococcal infections, different presentations, which we'll have to learn. If we don't learn, probably we'll miss them. Probably now this is not uncommon scenario when I'm talking in the presence of Dr. Raju Khopchandani. Probably we have learned many things from him regarding this condition. These scenarios probably, on the contrary, now probably a little bit overriding we are all diagnosing the condition, these type of the scenarios. Even the blue lines probably which has contributed by Dr. Raju Khopchandani, I have come across with the Kawasaki. With these all type of the presentations with our different cases, even the joint swellings and cracked lips and everything. Friends, at present I have learnt probably more than 32 cases of Kawasaki. Some of them are incomplete. Even the atypical, even with the pyorrhea and aseptic meningitis, I remember after a few days we could diagnose. They mentioned the neonatal, somehow I have not learned the neonatal Kawasaki, but they say that definitely it is there. I think this is the thing which we can learn. This was an 11.5 years female. Fever, high-grade pain in throat and skin rashes referred to me from the Bhavnagar for immunoglobulin because it's a Kawasaki. I said Kawasaki with this picture, but no fever. And CBC and everything is normal. Turned out to be something else, and that was the group A streptococcal positive, the throats of scarlet fever. Again, scarlet fever is not uncommon if I state over here. Probably if you are not getting, you are missing. Other in the practice, we commonly come across probably frequently now. I will not say infrequently. Rickettsia probably is not common in Gujarat, but we have learned from our friends from South Maharashtra and Karnataka, and particularly Atul Kulkarni. This is the patient which we saw from in the LG hospital. Rest of the things I have taken from Atul's presentation. And this patient was having this type of thing. I said it is Pseudomonas. But when we came to know that patient is from South Maharashtra, and we took the help of Atul and confirmed that it is Rickettsia. So occasionally even, may not be common, but Rickettsia is also known to us. I remember this patient was 6 years, cough was very prominent feature, what mother was complaining. And chest pain and the few bronchi. CBC normal, and this was the X-ray picture. But if you look at the skin rashes over the face, and with that we went for the workup, even the cold agglutinin direct Coombs test and even the mycoplasma for IgM was positive. This was the patient of 6.5 years from Ahmedabad itself. Friends, what I want to convey, mycoplasma is not uncommon. I would say not even simple pneumonia. with involvement of CNS and other features, the only thing that we should be aware, and at the right time we'll have to go for thought and confirm it, and patients are there. In the 2006, when Nitin was president, I said that HIV is not the problem of Gujarat. It is the problem of Maharashtra, Tamil Nadu, and some other states. Nitin told that probably you don't know. And to be very frank, I agree. These patients were from Tharad, with scabies and very bad inguinal lymph node. You can look at this X-ray, CT scan. Even in my LG hospital, to be very frank, I will say, which I don't expect, gastric aspirate showed the AFB. Which AFB? Even the MDR. And MDR with the HIV. So probably this is the new developments which we'll have to aware, and probably to be very frank, I will have to learn how we can manage these patients. Probably it is not common with us. I remember probably Dr. Raju also knows, because this patient was referred to him late, but when the patient came to me, 4 years, fever of 3.5 months, child was hospitalized at one hospital for more than 1 month, every antibiotic was given. Even the skin rashes, father came with the video that these rashes are only at the time of fever. Later on it disappears. If you see the leukocytosis, thrombocytosis, acute phase reactants, and these are the rashes, and I probably now in the morning we learned. Probably this is little bit new, what he discussed in the morning, difficult for us probably to understand, but I'm sure that we'll have to be trained now. I said we'll have to learn, and these are the fields probably which lacking with us. And therefore patient remained for 1 month in the hospital. This was the 10 months male which I saw in the 2001 from Modasa. Father is doing the very good tuition in the 12th maths and science. And later on when they came to me, everything was not showing anything. We thought of the renal tubular disorder. Every time hospitalized with some dehydration. And later on I thought the renal tubular acidosis. To our utter surprise at 2 different laboratories, alkalosis, metabolic, low potassium. I'm talking of 2001. I was not aware. And therefore I said probably it is some renal tubular disorder, but doing very well with the potassium. We discharge. Meanwhile, after the month or so, Dr. Gunjan, probably the Gandhinagar, he talked to me that there is one patient with severe dehydration, child of some engineer from Chennai, and I'm coming to you. Father showed me the discharge card. कि सर 40 मिलियन पोटेशियम से नहीं चाले तो मैं 60 आपो तो मारू चाइल्ड थे जा तो बार्टर सिंड्रोम छे. And that day I learned कि आपको पेलू discharge छे पण बार्टर छे. And from 2001 I learned the barter, and now probably as he enters from gate I say it is barter, and we have the more than 8 patients. 2 patients I said pseudo barter, looking like barter. मैंने फादर ने कहा सब बार्टर चौक्कस ने मैं कीधुं ચોક્કસ અને ના રિકવરી થાય તો બાર્ટર નહીં તો cystic fibrosis, and turn out to be the 2 patients of cystic fibrosis from the pseudo barter. Friends, we'll have to learn from 2001, which I learned from the barter probably. I remember one of my students when discussing in the Vadia with Dr. Uma Ali, from second slide he says, Madam, it is barter. And this, I think, once you are sensitized, you will be able to work. This was a 10 years old male with fever of high grade, abdominal pain and vomiting, decreased appetite, skin rashes. This patient was this Selby for more than 10 days. You understand Selby and 10 days, sufficient to say. And child was on antiepileptic drugs due for the convulsions. Every specialist, because jaundice was there, renal problem was there, rashes was there, dermatologist was there, infectious specialist was there. What I saw, febrile child, rashes, lymphadenopathy, jaundice, hepatomegaly. These were the findings on examination. Investigations, leukocytosis, eosinophilia, more than 1,000. And with that, raised direct type of bilirubin, SGPT, seromarkers, everything were excluded. I said it is Drace syndrome. And that is the problem of this. And later on, after the 6 months, I think last clinical meeting was discussed that again, I think Dr. Janti, the secretary himself, sent the second patient after 6 months. I said it is Drace only. Now we'll have to undress him. The only thing that we'll have to diagnose. And that's the thing that how we are learning. Friends, I made it routine. Yeah, previous slide is Nelson. There is a drug rash, eosinophilia, systemic symptom, that is a Drace. And this is the classical which I have mentioned in the previous case, which is given, table is there in the Nelson. Friends, what I want to convey, the message, if any new, this is routine to my residents, any new or unexplainable new symptom or sign develops, to diagnose case of pneumonia or enteric, which I have said, I say it is first check whether the drug is responsible. Most of the times we'll get yes. So probably history of drug is also very, very important. Investigations, I think Dr. Raju told in the morning, rheumatology, that means not the set of the investigations. Probably true for any condition. First, make the rational, derived, working clinical diagnosis, what probably Dr. Ambedkar is saying since many years. First, answer the diagnosis, may be wrong. Decide whether the investigations are required. If I say diagnosis is clear, there is no need of confirmation, it does not help me for monitoring, don't go for the investigations. We know that ADD, don't even ask for the stool examination, and never the stool culture, probably which we are doing and confusing to ourselves, and the why. When it is required, I know that the very threatened condition, go for the investigations, start the treatment, don't wait for that. Diphtheria, send the everything I will say investigate, but start the anti-diphtheria serum so that I can save the child. But suppose the enteric or pneumonia, I can wait even, I will not jump for the antibiotics, let me confirm. But once probably urgent, okay, and I know that I want to give the primaquine in a male child, I want to confirm the G6PD. So the friend's exact indication for the investigation. And therefore, whenever somebody is sending the reference to me, my first question, what help you want to from me? Any diagnostic, any therapeutic, any problematic, any complication, what help? You know that most of the times not able to answer, just refer to you, now you decide whatever you want to do. And friends, investigations should be planned pertaining to your diagnosis, not without diagnosis. Investigations are neither the shortcut for the history taking and examination nor final answer. Auscultate નહીં કરવાનું ઇકો કરાવવાનો એવું નહીં. CNS examination ના કરવા માટે જરૂરી નથી કે MRI બ્રેન કરાવી દીધું બધું આવી ગયું. બધું આવી ગયું નહીં, ત્યાંથી કોમ્પ્લિકેશન સ્ટાર્ટ થયું. That's a fact. And modern sophisticated aids and tests cannot substitute for this. On the contrary, of course, I will agree that modern technology aids to my clinical diagnosis. It makes me strong, and I will say I can confirm that what I say. That's role. We know that simple CBC always perform the habitual or daily routine. Look at this, and probably you can get the common condition, whether it is malaria, whether it is enteric, or whether any viral. And this is even pseudothrombocytopenia, the dengue fever. સાહેબ કોઈ દિવસ પ્લેટલેસ ઊંચું આવતું જ નથી, પેશન્ટ સારું છે, ઘેર જવા દો હવે, પ્લેટલેસ આવશે. If from the EDTA if you do, probably you will not get the correct answer. Some of the friends even from the hematologist I learned that in our own country, Bihar, Bengal and northeastern eastern part of our country, even the community, basically they have the platelets. Number will be less, but sufficient to protect. Probably here also it does not require any treatment. I remember that this child was 5 years, this weight was there, hemoglobin was low, almost indicating iron deficiency. If you look at this RDW, hemoglobin is low, but RDW is normal, probably it is not iron deficiency. Most of the times we are right. RDW should be raised. I said looking like iron deficiency, but not the RDW is raised, then something else. Went for the investigations, went for the HB electrophoresis, turned out to the beta thalassemia trait. Probably simple interpretation will give the diagnosis from the investigations, whatever the perform. This was an 8 years male, illness of 4 months from Sardar Nagar, Ahmedabad, presented with petechial spots and purpuric, isolated thrombocytopenia, diagnosed ITP, started the steroids. Unfortunately, child had the herpes zoster. They said due to the steroids, and child was having the chickenpox in the past, so this is possible. I said before we go for workup of bone marrow, let me go for the HIV, and turn out to be the positive. And therefore what I have derived or learned, any patient present with only thrombocytopenia, if I don't have the answer, I will say first tell me the HIV status. That's very important dictum, and that will help you. 7 years male, female with the fever of 3 months, pallor and liver and spleen, no lymphadenopathy. Investigation, everything. This patient was from Udaipur, related to the Chandravilas Hotel in Ahmedabad. Everything was negative. Referred to us, and to our utter surprise, when count was low, platelets was low, I said it is malignancy. Go for the bone marrow. From the bone marrow, my friend said there is no malignancy. After 5 days, I got the culture Salmonella typhi. Everything was negative. Friends, if I want to share, I'm sure that it increase our confidence of our GCS Medical College in the 4 years, 4-5 years. I joined probably in the 2011, 4.5 years. Total 274 culture positive enteric fever. Culture positive I'm talking. And Salmonella typhi 238, but paratyphi 331. paratype is coming up. I will say this credit goes to our microbiology department of Urvesh Mehta and others. Friends, this was a 9-year-old child from Rajkot. Any other species probably. There are typhi, paratyphi beyond that also there. And this was a 9-year-old male, fever of long duration of 5 weeks, hepatosplenomegaly, lymphadenopathy, everything was negative. Pyrex of unknown origin by definition. We went for the workup, turned out to the brucellosis. But that patient deteriorated very fast. And I said, why deteriorating fast? We went for the workup and came to know it is brucellosis with HLH. And now we have the brucellosis 17 patients, HLH 6 patients. All the 6 patients secondary for us, not the primary, which I am learning from the hematologist that primary is also fairly common and prognosis is not good. This is from the GCS Medical College, blood culture positive brucellosis 3 patient, which will get the report after 1 month. And tell your friend that keep the culture for more than even the 4 weeks for the brucellosis. And this is absolutely documented with the name of the person and even the dates, and that increases our confidence and probably learning of for the pediatrics. Friends, I think now the gradual culture is coming up for the culture. I'm happy. I will have to change the statement, but still probably it requires more. Send the blood and urine samples before starting the antibiotics, make the rule, maybe probably blindly, but it is very important. And this is a dictum to my residents. Any material, bone marrow, CSA, fasciitic, pleural fluid, lymph node, ક્યાંથી રસ્તામાંથી મળે તો પણ send for the culture. I tell my resident that if you have not sent the for culture, you will be punished. Because I am learning that which we have not thought of. આપણે વિચારીને પેલા ફોન કરે કે સાહેબ આ તો આ છે. આને કે તો ચોપડીએ ખોલવી પડશે, નામે સાંભળ્યું નથી. That's the, I will say, reward of the culture, and that we'll have to learn. This was a 3 years male, hospitalized 6 times at my own place because nephew of my chartered accountant. Neonatal remission at some other place. Later on I said bronchiolitis, valry, bronchial asthma, pneumonia, all were diagnosed by me. સારું છે કોઈ રેસિડેન્ટે કહ્યું નથી. Otherwise difficult. But when the child there was a failure to thrive and clubbing, this was almost 15 years back. And then we went for the x-rays, trying to understand, went for the CT scan. And then I understood that probably it is something else. And turned out to be the first case of the cystic fibrosis for me, probably 15 years back. I think you can see even the date somewhere in 2004. This was done at genetic department at AIMS under Sushil Kabra and Madhulika. And from that I started to learn the cystic fibrosis. And today I have more than 22 cases confirmed, sweat chloride only at AIMS by Sushil Kabra only, I will say. Then I don't accept anything. Gradually I'm learning that it definitely makes it. Even the various presentations, all of you know, I will not go into the details. This was a 2-month-old child, breathlessness and lethargic 3 days. Diagnosis septicemia by Dr. Dinesh Patel from Mudas, I remember. This was also long back. ABG was showing this. We were not knowing that what we are treating and what we are dealing. But thought of some metabolic disorder. Lecture attend કર્યો છે એ વખતે, 16 years back. And turned out to be even had lots of problem and complications, very precious child, immunodeficiency, pneumonias, required even the 16 aliquots of the blood components. One stage grandfather said, ઘેર જવા દો, બધું રહેવા દો. But meanwhile, we got the biotinate deficiency. Child survived, at present 11 years old, studying in standard 6, just came 3 months back to me for follow-up of another child. And I came to know that this child is doing very well. Probably from that day, I started to learn the metabolic disorders. Later on, I think recently from Mehsana, only the friends must be knowing, Tay-Sachs disease and cherry red spot seen by Dr. Rohit Desai in Ahmedabad. Later on, where we confirm the exosaminase A enzyme deficiency and Tay-Sachs disease. And from that, we have the Hartnup disease, we have the porphyria, Farber's disease, glutaric aciduria, probably any metabolic disorder you say from the Nielsen, almost probably we have come across in the practice. And if I give the account, only 12 undiagnosed before we do anything, probably died or something, but 79, all the varieties of the metabolic disorder, probably in the span of 15 years we have learned. Friends, this is quite interesting patient, 5.5 years. Illness of 3 years, this patient is from Pali from Rajasthan. Diarrhea, distension, pain in abdomen, voracious appetite, failure to thrive, pallor, hospital 4 times, once it was done laparotomy in Ahmedabad for the obstruction, intestinal obstruction. And when this patient, I remember that I referred to the Delhi went for the Loknayak Hospital. Dr. S.K. Mittal did the endoscopy and the duodenal biopsy. Sir told me, Baldev, celiac disease padho. And probably from that day I started to learn the celiac disease. And this is the confirmed from that hospital, AIMS, and later on, at present we are following 28 cases of the celiac with a different presentation. May come simply as a rickets, may come with spasms, may come with just short stature, not necessarily diarrhea. I think that's very important that we'll have to learn. And I know that now the advancement of technology and investigations is there, we'll have to adapt ourselves how to use it. Cytomegalo, in last 6 months, we got the 2 patients. I sent the patient to Medanta. Dr. Neelam Raval did it, Neelam Mohan. This was a CMA PCR positive. We learned that which drug we can give derivative of genciclovir, and after that the patient is responding very well. Clinically, jaundice, liver, everything disappeared. And you can see the PCR, they significantly reduced the viral load. The point, friend, which I want to share with you, learn this modern advanced technology. Probably everything, for every disease, we have the answer. Now, don't say that there is no treatment for this, or this disease cannot be confirmed. Probably that days have gone. Even I know that not uncommon probably for us, CSF, MRI, even the PCR you can see from my own GCS patient, and that successfully treated HSV probably not uncommon, especially for the neurologist. This was the 8-month-old child from Vapi. I think Digant maybe remember, because this patient was referred by the Kirit Sisodia. And frequency of stool from 8 to 10 times. Not gaining weight, losing weight. Hospitalized once in KM hospital for 15 days at Mumbai. Full term 3 kg weight, but 8 months only 3.8. That was the problem. Hypotonia, everything developed. I said I could not answer anything. At midnight I sat to check all the investigations. Answer was already investigated. 2 different pathologists mentioned some irregular margin of RBC. They could not say they are the acanthocytes. And different laboratory 50 and 60 cholesterol. Open the Nelson, only 5 lines mentioned, but that is the A beta lipoproteinemia. And I think it's not uncommon if you go for the simply, and what I want to convey, after the investigations, interpret it properly. Take some time, go in the details. Every page something is mentioned that we have to search for, and answer is there. Friends, this was a 40 days mail from my own LG hospital. Diagnosed septicemia, treated, patient Saru Sahib, Raja apai gayi, readmitted, CSF meningitis, and you can see the miserable situation of the child with the CT scan. Went for the shunt, but partial treated pyogenic. Very important message, whether the patient is ready or not, listen to you, following or not following, without the probably confirmation, the newborn particularly, without the CSF, don't start the antibiotic. Probably it's a crime on our part. We made the miserable life of the whole child and the family. Probably we do not want to be the component of this management. I think that as a quality offer, we'll have to decide today. Friends, probably with this clinical information, many things are there for me to mention. Very difficult to mention the defined time. I will take only 5 minutes more. Efficient administration is very important. Probably I'm learning from my friends like Dr. Satish Pandya, how you can efficiently administer probably everything. And we know it's a time. We'll have to make for the teamwork or group, probably gradually coming up. Train your staff, everything Dr. Prajapati or Dr. Satish Pandya or even the Dr. Chetan Bhai cannot do, and Chetan Bhai has a very big probably, nobody can do. We'll have to go for the assignment of the duty, put on the papers, check it, whether everybody is doing properly or not, and go for the frequent changes, and make the family bonding. I think that's very important, otherwise ultimately we fail. So I think that is also very important that we'll have to know. I think in the past we were knowing that Je Ochu Bole a mota consultant. Now the time has changed. Go for best counseling, explain everything, not only for taking the best lecture and to give the quality offer, but for my protection from the legal. And therefore, I think it is very important. Everything, documentation and explanation, and that counseling is the demand of this time. We'll have to train. Probably it's a compulsory. Medical audit, I remember that when we were resident, Madam Desai, asking every Monday case discussion. And death thayu to pelanu aap death to thai jai resident no. Because he has to answer everything. Kyare avitu, tyesu karyu, au kem karyu, au kari shakya hot. And I know it makes difference in that. And I think that we'll have to learn. It is also part of medical audit. We know that perinatal meeting, we were learning many things, not only to blame the obstetrician. આપણને લાગે ભલે બ્લેમ તો કરે પણ પ્રોબ્લેમ તો આપણો છે. So I think that is also very important. Health policy probably is, we are learning from Dr. Dhodak, and we can take the help of all these people. They will help us. I think prescription analysis, long back some of the people have done. I know the rational antibiotic and all the groups, Dr. Phatak and Dr. Satish Pandey and team started long back. I think probably somehow it is not working the way in which should. Probably every practitioner should be the component of it. I think again I will request this gathering that pay the attention of probably it will be the best exercise of learning for us. Post-mortem analysis have probably run away, but best exercise for us to learn. We'll have to go for that. Research, આપણે તો એલજીમાં છીએ એટલે એલજીમાં તો રિસર્ચ શું થાય? સાહેબ હવે મારી પ્રાઇવેટ હોસ્પિટલ 5-10 બેડની જેમાં રિસર્ચ શું થાય? વિલિયમ ઓસ્લર સેડ લોંગ બેક, ઓબ્ઝર્વ, રેકોર્ડ, ટેબ્યુલેટ, કોમ્યુનિકેટ. મેં જેટલા કલ્ચર પોઝિટિવ આવે એટલે તમને કહી શકું ને, ભલે વધારે કંઈ મને રિસર્ચ નથી આવડ્યું. ઇફ યુ રીડ ડૉક્ટર નાડાસ નોન પીડિયાટિક કાર્ડિયોલોજિસ્ટ, એની હિસ્ટ્રી જુઓ તો કઈ રીતના એક પિંક કાર્ડ ને બ્લુ કાર્ડ, બે કાર્ડ જ હતા. From that card, what he gave, the approach to congenital heart disease, no cardiologist able to challenge. We know, I think, Dr. Kawasaki, if you see, what was his observation? Simply observation કે આવું કોઈક disease છે. Kawasaki તો પછી ખબર પડી. So I think this is the thing, whatever we observe, we can at least do. And I think it is also some contribution. Okay, may not be that methodological, probably may not be that advanced. And if you have the opportunity, you can go for that advanced research also. Friends, ethics is very important. મને લાગે છે કે આના શહેરો બધા જાદુ જતા રહેશે. ભલે આપણે જાતે માનીએ કે બહુ હોશિયાર છીએ, પણ આઈ એમ શ્યોર કંઈ રહેતી નથી બહુ લાંબો સમય. એસ્ટાબ્લિશ ઓફ રેપ્યુટેશન ઇઝ વેરી ઇમ્પોર્ટન્ટ. હું તો મારા સ્ટુડન્ટ એમ જ કહું જેને હું ગમતો નથી બીજા કોઈ કારણસર, પણ પ્રેક્ટિસમાં મારા વિશે ઘસાતો બોલી ના શકે એટલું હોવું જોઈએ. ભલે આમ બળદેવી ગમતા નથી, પણ ઓકે. અને આઈ એમ શ્યોર કે દેટ રેપ્યુટેશન ઇઝ વેરી ઇમ્પોર્ટન્ટ. નો યોર લિમિટેશન. નાઉ ઓલવેઝ વિધાઉટ એન હેઝિટેશન આઈ સે કે સિદ્ધાર્થે એમબીબીએસમાં મારી ટર્મ એની આવી હતી, પણ નાવ ફોર ન્યુરોલોજિકલ પ્રોબ્લેમ હી વિલ બી ધ ગુડ હેલ્પ, એન્ડ વિધાઉટ એન હેઝિટેશન આઈ શુડ બી એબલ ટુ ડુ. I'm sure that that is very important. Ethics and quality, they are always together. We cannot separate them. Conscience and ethics, they are going to be there. And we know that morally and legally we are accountable to the society. We cannot escape from ourselves, our responsibility. Values follow થઈ શકે કે ના શકે એ આપણો પ્રોબ્લેમ છે, એની વેલ્યુ તો છે જ. So that we'll have to decide that what is to be done. Friends, I will not go for the repeat of the summary. Probably most of the messages which I have mentioned in my talk, there is the summary. But it's very important that methodological and well-organized clinical examination is very important. કોરિડોરમાં જવાબ ના આપે મેલેરિયા છે ટ્રીટમેન્ટ લઈ લેજે, ના ગમે તો કહેવું પડે ટાઈમ લેવાનો, ના હું રાત્રે બેસીશ ત્યારે આવવાનું, હું એક્ઝામિન કરીને પછી કહીશ કે કંઈ નહીં લેવાનું, પણ નહીં લેવાનું એવું કહેવા માટે મારે જોવું તો પડશે. અને આપણા જ રિલેટિવ ના ડિસ્પ્લીસ થાય તો થવા દેવાના, નો પ્રોબ્લેમ. વોટ આઈ મીન ટુ સે, પ્રોબ્લી ટુ સમ રીઝન્સ વી ગો ફોર ધ કોમ્પ્રોમાઇઝ, એન્ડ દેન વી ફેસ ધ સમ પ્રોબ્લી લાઈફ થ્રેટનિંગ પ્રોબ્લેમ ઓર કોમ્પ્લિકેશન દેટ વી કેન નોટ ઓફર, વી કેન નોટ ડુ. Probably very important, most errors in the medicine which I have made the routine, કદાચ મારા રેસિડન્ટ અઠવાડિયામાં 5-6 વખત સાંભળવું જ પડતું હશે કે most of the clinical mistakes may not be lack of knowledge. Lack of knowledge હશે પણ percentage ઓછા છે, પણ lack of sincerity. Undiscerned taste જેને આવડ્યું નહીં, જોયું નહીં. We know, and I think that is very important. And everything is known. Second thing, always keep the habit of common conditions first in my practice. Uncommon wood pasture syndrome છેલ્લે, કારણ કે ગુડ પાસ્ચરે જોયો પછી કદાચ કોઈએ હાર્ડલી જોયો હોય, રાઈટ? એટલે આપણે એમાં બહુ પડવાની જરૂર નહીં. એઝ અ જનરલ પીડિયાટ્રિશિયન, લાઈક ડૉક્ટર રાજુ ખોપચંદ and others to do in the specialty fields. Friends, very important, they say man is always learning. મેં હમણાં જ ડૉક્ટર રાજુ ખોપચંદાની સાથે વાત કરી. મેડમ દેસાઈ ઇન્ડિયન પીડિયાટિક્સ વાંચે ને પછી રાજલને ફોન કરે કે આ ઇન્ડિયન પીડિયાટિક્સમાં આ આર્ટિકલનું શું છે તું મને જરા કહેજે. રાજલે એમ કહે મેડમ મારે વાંચવાનું બાકી છે, અમારે વાંચવાનું બાકી છે. એટ 87 મેડમે ઇન્ડિયન પીડિયાટિક્સ વાંચી નાખ્યું છે, એન્ડ દેટ્સ વાય શી ઇઝ નોટ ઓલ્ડ. એટ ધ 87 શી ઇઝ એબલ ટુ કમ. ફ્રેન્ડ્સ, વીલ હેવ ટુ લર્ન. Man is always learning, and the day he stops to learning becomes old. એટલે આપણે ક્યારે ઓલ્ડ થવું આપણે નક્કી કરવાનો. I think that's when, therefore we'll have to continue. Friends, very important what I said. Documentation is very important point of analysis of cases. I'm able to say all the cases because from 1988 when I started my practice, within 5 minutes you'll get the case paper of every patient. And therefore, I am able to give the documents of every patient. Not only for, I will say, but ensure the transparency, honesty in my practice. Very frequently, Dr. Ambedkar mentions. And બધું મને જવા દો એમ કે લીગલ બધું એથિક્સ તો બટ ફોર લીગલ પ્રોટેક્શન પ્રોબ્લેમ થયો ત્યાર તો આપણે કોણ સાંભળશે ઇફ ઇટ ઇઝ નોટ ડોક્યુમેન્ટેડ સો નાવ આઈ એમ ટેલિંગ માય સ્ટુડન્ટ્સ પીડિયાટિક્સ તો ખરું જ લીગલી આવડવું પડશે અને બધું આવડ્યું પણ જો ના આવડ્યું સપડાયા તો ગ્રેટેસ્ટ ટ્રબલ સો આઈ થિંક ધીસ ઇઝ ઓલ્સો ઇમ્પોર્ટન્ટ મેસેજ વિચ આઈ વોન્ટ ટુ કન્વે ફ્રેન્ડ્સ આઈ થિંક એટ ધ એન્ડ ઓર એટ ધ લાસ્ટ બટ નેવર ધ લિસ્ટ આપણે જાણીએ છીએ કોઈનો જાદુ એમને એમ ચાલે નહીં. And for this, I would like to compliment my family. To be very frank, probably this is an opportunity to express my feelings. But I'm sure that only due to Rajal, I could do all the things in the practice and probably everywhere. I have two lovely daughters also. They allowed me probably so many things at the cost of many of probably their losses. And now, really, we are so happy in the recent time, my family, because there is an entry of very dynamic, my son-in-law in my family. And I'm sure that probably with this, now my strength is increased and I'm going to do more and more in the future because as I told you, I don't want to be the old person. And friends, I think before I go for the thank you, I would like to express some of the acknowledgements to some of the friends who have really helped me. Always I say in my round also, I am the most fortunate person that I got every person good. Besides teacher, Madam Desai and Madam Vani, Anjana Ben, I remember that I got the very nice residents, registrars, Dr. Arbisha and Dr. Rajesh Trivedi, to be very frank, best registrars for me. I learned many things from them. My batchmates, અત્યારે અમે અમુક દિવસે ફોન ઉપર નામ મળીએ તો ના ચાલે. And that Dr. Arvind from Mehsana, Dr. L.J. Shah from Godhra, એટલે જે કે આ બધી માથાકૂટ છે તું જોજે એલજે તેટલું જ કહી દે. Dr. Suma, and to be very frank, not only ourselves, our children and we have the family together, the bonding of that develop. And really to be very frank, that's a good asset and help to me. I remember that when I was working in the LG hospital, I was not the head of the unit. Dr. Harish Parikh was the head of the unit, my senior person. Very nice person. રાઉન્ડ એ લેતા હોય સાહેબને કંઈ પ્રોબ્લેમ હોય તો કે એ રેસિડેન્ટને કંઈક સાહેબને બતાવી દેજે કે એ પ્રમાણે કરજે. આઈ થિંક ઓલ ઓફ અસ નો અવર લિમિટેશન્સ આપણે કોઈને એવું કહેતા નથી. આઈ નો દેટ હી વોઝ ટેલિંગ મી એન્ડ હી ગેવ મી ધ ઓપોર્ચ્યુનિટી ટુ લર્ન સો મેની થિંગ્સ and probably so my even the junior friends. Probably every pediatrician from Gujarat, probably even Rajasthan and Madhya Pradesh, they have contributed in my development and I thought that let me at least acknowledge over here. And naturally, my students, લોકો મારા વિશે કોમેન્ટે કરે રસ્તામાં મળે તો એને ભણવું કે ના ભણવું ભણાઈ તો દેવાનું છે અને હું તો એને એમ કહું તારે સાંભળો ના સાંભળ પણ હું સાંભળું એટલે મારો તો પાકો થઈ જાય. એન્ડ ટુ બી વેરી ફ્રેન્ક I will never probably underestimate my students and my residents. Many times now I am learning even કારણ કે વધારે વાંચીને આવે મને એટલી ખબર ના પણ હોય. And with this, thank you very much friends for patient listening. Again, thanks a lot to the office bearers and the committee for awarding me the very prestigious oration. To be very frank, I consider myself most fortunate because I got the opportunity to deliver this talk in the presence of my own teacher, madam, on her name when the prestigious oration is there, and probably she should be happy that what she has taught us, and probably that not a single day have been passed where we have not mentioned the name of Dr. Mrs. A.B. Desai. And with that, probably, thank you, friends, for giving this opportunity.
Thank you very much, sir. We are fortunate to hear, sir. Now we
now request Dr. Mrs. A.B. Desai, Madam, President, AOP Gujarat, Dr. Swati, Dr. J.K. Gosai, to come forward and present the certificate and memento to Dr. Baldev Bhai, sir.
Thank you, Hemant Bhai. Now friends, this is a time for which we were waiting for and this prestigious award has been given to Dr. Baldev Bhai Prajapati. Dr. Mrs. A.B. Desai Oration Award, Academy of Pediatrics, Gujarat. Office bearers and members of AOP Gujarat are very happy to award Dr. Mrs. A.B. Desai Oration Award to Dr. Baldevbhai Prajapati on 12th of June 2016 at Midterm Scientific Meet at Mehsana, which is organized by AOP Mehsana unit and association with NGPA. Dr. Swati Popat, President, and Dr. Jayanti Gosai as a Secretary. Thank you very much.
I request Dr. Dhiren Bhai to present certificate and memento to Dr. Baldev Bhai, sir. Thank you, sir.
Yes, हमने पहला Laksu.
Let me show you.
Today I am very fortunate and I would like to share one very great announcement that respected Dr. A.B. Desai ma'am wants to contribute once again to A.B. Desai Oration to AOP Gujarat. Thank you very much. Thank you, madam.
Yes.
Wait.
Yes.